everyone can mosey back in and settle in. I never admire like the last two speakers at a conference because even when they're absolutely wonderful, people start to get a little antsy. So if you feel like you need to get up and move around, I don't think any feelings will be hurt, but I would like to keep it rolling so that we can give everyone their time. So, okay, I'm going to introduce Sheren Gaulbert. She is a qualified cognitive hypnotherapist since 2011 and focuses her practice on working with people living with persisting pain. A proponent of interdisciplinary collaborative treatment teams to deliver better care, she uses her 30 years experience as a speaker, mentor, and coach, and educator to run experiential courses for multidisciplinary clinicians and therapists with an interest in pain, ready to learn from different modalities. Sheren has a specialist interest in female and male pelvic pain. As a trustee of the Vulval Pain Society, organizes and hosts webinars, live streams, and in-person conferences, bringing together multidisciplinary pain clinicians, researchers, and patients to foster meaningful, productive discussions. So I'd like to invite Sheren Gaulbert to come on up.
Thank you for that introduction, Sarah. And, I don't know if Rajam is in the room, but I'm so grateful to be here in person because I've only ever been attending online, so it's wonderful. So welcome to Persuading Change, pointers from Conversational cognitive hypnotherapy. And if you're wondering how to pronounce my name, Sheren rhymes with heron. This picture was taken right here at the Dana, so if you haven't spotted the herons yet, go ahead and seek them out. They're extraordinary. So Sheren Gaulbert. Hopefully that will stick in your mind. So as Sarah mentioned, I have a background in coaching and mentoring going back some decades. I'm also a trauma-informed cognitive hypnotherapist, QCH for short. We'll talk a little bit more about QCH in a bit. In between those periods of time, I spent the worst decade of my life with persistent pain. And that was following intermittent pain for quite a bit of my life prior to that. These days, I work with people living with pain. I run programs for hypnotherapists from different hypnotherapy schools so that they may make ethical choices when they're treating that unique individual in front of them with an underpinning of pain science, or the best we know in terms of how pain works. And I guide multidisciplinary clinicians to somatically track some challenging reactions or emotions within them so that they may get some sense of growth and understanding, recognizing their biases and working through those. Embodying the space of a patient or another human being to gain a different perspective, nonverbal communication. Some of you may have seen 2021 San Diego Pain Summit. I covered nonverbal communication. A short presentation, about 20 minutes. If you haven't seen it, go ahead and seek that out to watch. And today we'll be looking at language patterns. I belong to a number of associations, some you'll see here. And as Sarah mentioned, I'm a trustee of the Vulval Pain Society, and we bring together people living with vulval pain, multidisciplinary clinicians, researchers. We promote the work of researchers, and we bring them all together in one room at our national conference. And it's such a beautiful thing to see, having that space to have some really meaningful, important discussions between all of those groups, and we've been doing that for a very long time. More recently, I've had long COVID, and that's thrown a spanner in the works. And yesterday, I overdid it a little bit. Now, I'm mostly better, but if I overdo it in terms of my cognitive energy, then like this morning, it means that I feel exhausted, perhaps aches and pains, a bit of a hemiplegic migraine, not particularly fun, and I don't work quite as efficiently. So I'll be referring to my notes. Bear with me. So an overview, we're going to be looking very briefly at some language patterns, how you'll be able to listen out for certain types of language the people you work with might use that could possibly indicate priors or beliefs they have that may be hindering their progress. And then some simple word shifts that you can use to encourage change. And then some questions that can reveal, again, priors, beliefs, and one question that can potentially indicate a need for a psychologically informed therapist to be part of that multidisciplinary team. And then we're going to wrap up with a tool, a technique to, again, potentially start reshaping someone's experience. And I would say, curiosity is a really lovely thing. And children are great at it. And they sponge up lots, don't they? And if we can just bring that curiosity, then we could be open to possibilities, to learning. And I'd suggest you have perhaps a client or a patient in mind as you go through, or it might be that as I mention something, you think, oh yeah, I know that fits with that person that I've seen. Or it might be next time you're working with someone that it comes to mind, that thing that Sheren was talking about, that I could utilize that here. So let's start with hypnotherapy. I know here in the States, I think you use the word hypnosis rather than hypnotherapy. I might use them interchangeably. They mean the same thing. And broadly speaking, I'm splitting them into direct and indirect types of hypnosis. So the direct form can be script-based. So that would mean, in the simplest of terms, if someone had, let's say, high anxiety and they wanted to relax a little bit, then they might get read a script from a book of scripts and asked to walk on a beach with the sand between their toes, watching the sun and hearing the sea. What might be a problem with that, do you think? Yeah.
Maybe they don't want to be at the beach.
Maybe they don't want to be on the beach. I mean, it sounds like a lovely place for most of us, I imagine, but maybe they don't want to be there. What if it's linked to a traumatic experience for them? And what if they just have somewhere better? Wouldn't it be lovely if we just asked them, where's your relaxing space? What would that look like for you? And it can also be labels-based. And I hang out on a number of hypnotherapy forums, and a question that comes up really regularly is, oh, I've got someone with fibromyalgia, or I've got someone who's got a migraine, or with low back pain. Has anyone treated this before? What script do you use? What technique do you use? What do you do? And of course, the problem with that is we're not seeing that unique individual in front of us. You can hear my biases, right? And indirect, it may be conversational, and it may be script-based, but there's a possibility of working out what that person's individual preferences are, and you might fill in the blanks. Which do you think has more efficacy in terms of results? Who thinks the direct approach, script-based, labels-based, is better in terms of results? Okay. One person, anyone else? Just one person, okay. And who thinks the indirect approach might be better in terms of results. So a few more of you. That's the individual. But here's the thing. Direct, traditionally worded hypnotic techniques appear to be just as effective as permissive, open-ended, indirect suggestions. Now, this is an old study. There aren't that many good quality studies about. So if this methodological review showed that both are equal in terms of efficacy, what do you think my problem with that is? Is efficacy between the two what's really important? No. I'm more concerned about locus of control, about self-efficacy. If someone goes to a hypnotist or hypnotherapist and they experience the direct traditional approach, that seems very much like an external locus of control. They've gone along to be fixed by someone else, and they're about to be told how they can experience that shift. So they're looking outside of them for an expert. But really, ideally, we want someone in an internal locus of control, their self-efficacy, their sense of agency. That's the stronger position, because ultimately we want the people we work with not to be reliant on us as a crutch. The best thing we can do is allow them to fly. Look, I have to be fair. Mark Jensen's book, it's part of the Treatments That Work series, Hypnosis for Chronic Pain Management. It's a therapist guide, and there's also another guide that goes alongside that. Very straightforward books for the novice hypnotherapist, and I would say probably for anyone, if you can read. You can read, right? So you can read a script, and he does get you to explore what a person's preferences, values might be, and you fill in those blanks. But the focus here is still, as you see, for chronic pain management. It's on pain reduction or pain modification. And there's a reliability on a depth of trance. So you might have seen, look, although it's nothing like stage hypnosis, I imagine many of you have an idea of what it's like, and there may be steps that people go down, or they're counted down to achieve a state of very deep relaxation. So that's traditional hypnotherapy, is reliant on these suggestibility scales. But there's a problem with that. Not everyone is suggestible in that way, and not everyone can get to that depth of trance. Who's familiar with Snow World, the VR game? There's a few of you, okay. It's an old paper, and Snow World was used with burns victims. So when they were undergoing wound care, their bandages were being changed. That was a really kind of painful time for them. And analgesics don't tend to work very well. Opioids don't tend to work very well. They're in a lot of agony. But with Snow World, they're given a VR headset, and they get to chuck snowballs at penguins and snowmen and various things, and there's a sound that accompanies every time they hit something with a snowball. And with them immersed in that experience, 35 to 50% reduction in pain was experienced whilst they were immersed in the game. So whilst they were in it, who was going to be in a VR headset the whole time? But whilst they're in it, there was a reduction in pain. It was also tested against hypnosis, but only 25% of the participants actually had any effect from the hypnosis. And again, there's a dependency there, I imagine, on that depth state, that hypnotizability. So using that kind of traditional way of practicing hypnosis. And look, maybe that was what was appropriate here. But it seems a bit strange to me, that 25%, because if we can imagine, then essentially we have the ability to enter a particular trance state. Now, aphantasia is a condition of reduced or absent voluntary imagery that was coined by a professor of cognitive and behavioral neurology at the University of Exeter, Adam Zeman, and it affects around 3 to 4% of the population. And over half of those can dream. So they do have access to internal imagery. So we're probably only looking at 2% who are truly aphantasic, who can't visualize or imagine in that way. Although very small study at that point in time, that's 2015, this is a new area, so there's only 21 participants, but there's ongoing research in this area. But could it be that rather than a person's own preferred imagery, a direct traditional hypnosis script was used against Snow World, and that's why it only had a 25% chance of efficacy. And then there's this scoping review on hypnosis in 2020. Good news. It appears to be as effective as other psychological pain treatments. Great. Not so great. Quality of the trials on the efficacy of hypnosis for pain management remains pretty low. Some suggestions were made for future research in the area to detail the randomization procedures, to conceal the treatment allocation, so if it's against CBT or ACT or whatever it might be. To blind the individuals, now it'd be very difficult to blind the hypnotist, because I imagine they'll know what they're doing. But to blind the individuals performing the outcome assessments. And please register trials prior to a study enrollment. But this presentation isn't on direct pain reduction or modification. And if you caught Morton's talk yesterday, then you may ask what the favorable outcomes we witness are. You know, are they just everyday miracles? This stuff that we do, whatever modality we use. And perhaps rather than pain relief, it's engaging living in a life that you want to live. That's more important, the value, having your values met, as Nathan suggested. And whether it's serotonin or endorphins, other modulators that then mean that someone becomes more comfortable as a result of being more engaged in their life, in doing things that they enjoy doing, then we're winning, aren't we? So if we're better engaging with that unique individual in front of us, isn't that what they deserve? So, Quest Cognitive Hypnotherapy, QCH, we see trance as an everyday state, not some kind of special state. So think of it this way. So things that once upon a time we had to learn how to do, whether it's tying your shoelaces or brushing your teeth. You had to consciously learn how to do these things. But these days, I'm assuming in this room, you can do these things automatically, should you wish to. Certainly brush your teeth, I hope. Or you're taking a familiar journey, and the first time you took that journey, maybe you had to look it up. But once you've been on that journey time and time again, then you're probably not thinking about the journey and how to get there. And maybe sometimes you get to your destination and realize, I don't even remember the journey. I've just arrived. So this is autopilot. We've reached a level of unconscious competence. So the 4 stages of competence can start with unconscious incompetence. We don't know how to brush our teeth. You're kind of unaware that that skill even exists, and then you're taught it, and then you have to learn it. And then you get to a point where you're conscious, you're pretty incompetent at brushing your teeth. And then you get good at it, but you're still consciously aware and thinking about it. And then I'm assuming that the stage you're all at is unconscious competence at brushing your teeth or whatever it might be. And this unconscious competence can be seen as a trance state. So you're in an autopilot, you're in a trance. And there are lots of different trance states. So this chap on the left, so, this is where trance states might be problematic when we're overprotecting. How many times have you seen someone come into your clinic or into your space and they have an adapted way of moving, overprotecting, because they're in pain? Their body movements or their behavior altered as a result of their experience. And they may have a belief or a prior that the reason they're doing that is because they want to prevent themselves from doing harm or the pain from worsening. Whether they're aware of it or not, it becomes kind of unconscious, right? They're in that trance state. It's been done for them. And they may have been conscious of it at one point, and other times they don't even realize they're doing it. And it'll be up to us to go, that thing you're doing there, have you noticed that? What's going on there? And on the right is another type of trance state, which can be sensory distortion, where things seem different or we perceive things differently. Now, I sometimes get people to draw body schema. So draw yourself how you perceive yourself to be in this moment. What's your awareness of yourself? You're the embodied awareness of yourself. You can phrase that to match the person in front of you. So this is how this person felt herself to be. Now, I've used this with the people in my workshop, so no cheating. But those of you who weren't in my workshop, what do you think was going on with this client on the right-hand side, that she's drawn herself like that? Any ideas? No? She had pelvic pain. She didn't have a big behind or big hips. She had pelvic pain. This is how she perceived herself to be. And for her, just drawing that made her realize this is what I kind of see myself. This is how I see myself. This is not how she actually looks in the mirror. But her pelvic pain had become part of her identity, part of her very being. And it magnified what was going on for her. Another trance state is predicting the future. So predictive processing, that might be kind of cause and effect. If I do this, then this might happen. If I go and sit in that chair for over half an hour, then my pelvic pain might flare up, or whatever it might be. And replaying something that happened in the past. An accident that happened, or an event that happened that they believe triggered what's going on for them now, their persisting pain, or whatever else. And any type of absorbing state or flow, Deborah. If you're lost reading a book or watching something and you don't notice the passing of time, how often does that happen? You know, it can happen. You just get absorbed in something, and then you look at the time and you think, wow, time has sped by. So we're in a sort of time-distorted trance, if you like. And any type of flow state. So, Sherry, where are you? There you are. We came up with this masterpiece yesterday. Better than all of yours, I'm sure. We even did some noughts and crosses. Is that what you call it here, noughts and crosses? X's and O's, yeah. Tic-tac-toe, yeah. We did that just automatically. We're in a trance, right? So trance states are everyday states. So it can mean unconscious competence, autopilot, playing out the future or past rather than being in the present moment. So some kind of mindful exercise could bring them into the present moment. Being absorbed in something, being in flow, being dissociated. And what we're interested in is what trances are driving the, if you like, the problematic behaviors that might be exacerbating symptoms or maintaining symptoms. And we see those as the problem, right? So we use those trance states to dehypnotize people. I'm not going to show you how to do that today, unless you've got 10 months. So QCH is a wide framework. We treat the unique person. We want to understand the context within which they might notice things being worse. Also their journey, their challenges, their unique experience of pain, their embodied experience. We want to uncover priors, their beliefs, emotions, their thinking patterns, any type of anticipatory behaviors, that predictive processing. And whilst pain modification may come into the process at times for some people, really the focus is on moving them towards a sense of embodied safety and living a values-based life. And then the knock-on effect of that is that they may notice they're feeling more comfortable. And I'll introduce a simple tool a little bit later on. So we're going to jump onto some language patterns. Building safety, guiding them towards a value-based living. Okay, great. Actually, we use outcome measures. GAD-7, the Generalized Anxiety Disorder questionnaire. Some cognitive hypnotherapists will use this every session. I use it at the beginning and then potentially again at some other point. It just gives us it's not perfect, of course it's not, but it might highlight something else that's going on that has an amplifying factor. PHQ-9, the Personal Health Questionnaire, again, same sort of thing. It might highlight something. So this looks at depression levels. And this, I call it Schwemmwebs. I don't think it's pronounced like that. It's a short version of the Warwick-Edinburgh Mental Wellbeing Scale. And isn't it nice after tracking potential anxiety and depression that we also look at well-being? And if their scores are low, we might be looking at ways in which to take them up a level. And I was involved in a pilot study, which was published, I think it was 2015, using those outcome measures. And it was a practice-based study. So people coming to us would self-report using those outcome measures. Apart from the 19 clients that I contributed, the rest weren't people living with pain. And even though the results were favorable, we've got to keep in mind that someone who comes to see us as QCH, they're self-motivated. It's not really fair to have that measurement up against other perhaps psychological therapies where they may just be referred and they have to go and see them. People come and see us have chosen to come and see us, so they're already motivated. Okay. I want to mention that most of the people that come and see me are referred, but they're referred and then they do want to come and see me. But I don't take everyone on. And this is working out what our scope of experience is. So out of every 10 people who come for a consultation, and I offer them for free, I might take on 6 or 7 and refer the others on to whoever might be more appropriate than me. Whether that's a PT or back to their GP for more investigations, whoever that might be. So I always start with the end in mind, and in that consultation, there's all sorts of questions. Someone asked me the other day here, how long is your consultation? I said, ideally about 45 minutes, but sometimes it can go on. It might be an hour. I've had 2 hours. I've had one person who took a little bit longer than that. And we start with the end in mind. What is it the person wants? Now, if I ask you not to think of a blue elephant, what happens? Have you seen this blue elephant before? It's been flashing up on a number of slides, whether you've noticed this blue elephant or not. And for someone experiencing pain, if their goal is, I want to be pain-free, then there's a blue elephant right there. And so this is ironic process or ironic rebound. If you try not to think of it, what happens? We need to kind of process what that thing is that we're not meant to do, and then too late, we've done it. And Dostoevsky, in Winter Notes on Some Impressions, he said, try to pose for you this task, not to think of a polar bear, and you will see the cursed thing will come to mind every time. I've just turned the polar bear into a blue elephant. So start with the end in mind. So rather than pain-free, aim to uncover someone's values. So how do you do that? You could just ask them. You might have all sorts of ways. You could ask, what does pain stop you from doing? But that could be a blue elephant, potentially, right? What does pain stop you from doing? You're highlighting the fact that it's stopping them doing something. Maybe instead of that, you could ask, imagine you're living more of the life you wanted. What might you be doing that you currently aren't or you currently can't? What might you see that lets you know you've changed? So they're tuning into perhaps their facial expressions, their body language, their movements maybe. How might you sound better? Because they might sound louder, they might have a different pace, they may find their voice has a different timbre. And how might you feel different? They might say pain-free, but you can ask them, well, how would you feel different in terms of maybe emotions? Or if you're pain-free, what would that be like? What might you believe about yourself that you don't completely now? And once the problem is gone, what will become important to you? Because for many people living with persisting pain, if it's being ongoing, that has become the center. It's become their central focus. So what's going to be important to them after that? If their focus could be somewhere else. These are all ways of uncovering values. And what will you gain by achieving what you want? Now, you don't have to ask all these questions. There may be some that work better than others, and there's all sorts of ways you can uncover values, but these are just a few questions. And once a goal has been defined, this is a useful question. Now, I don't particularly like 1 to 10 scales, but for this, it can be quite useful. If someone has defined their goal, and then you ask on a 1 to 10 scale, how much do you want to achieve that goal? And they say about a 4 out of 10. It doesn't sound very compelling, does it? So what will then take it up to the next level would be the question. So if it's a 4 out of 10, what would need to happen to take it up to a 5 out of 10? And it might be it's not what they want at all. They want something else. But it can be a useful question to ask. You want to really take them up to a level that is meaningful for them. 4 out of 10 doesn't seem very compelling. And that number, it might be 6 out of 10 or 7 out of 10. It's whatever it means to that person. But 4 out of 10 and 5 out of 10 probably isn't going to cut it. And then once they've defined it, we chunk the goal. What may be this first small change you notice that lets you know you're moving towards that meaningful, values-based goal? Small, chunking, manageable steps, and the opportunity for them to notice those small changes which keep them motivated. Bite-sized. Opportunity for celebratory moments along the way, and you can celebrate along with them. So let's move on to listening and questioning. Okay, so I've just noticed the clock ticking down here. I'm going to speed up a bit. So if you hear someone say, "I can't," you might ask, well, what makes you say that? What might be the next small change of experience that lets you know you're moving towards that? What if you can? What if you could? If they say, "I should," or "I must do X, Y, or Z," well, according to whom? Who told you that? Is it a useful message? And make sure they want the change for themselves, that they haven't been sent there by someone else and they don't really want to be there. Unlikely to be successful, that journey, if they're not there for themselves. Well, they want that change as much for themselves as someone else, that's fine. So it's their values-based goal, not someone else's. Moving on to wording. So "I should" could be changed to "I could" or "I can." So "I should" does sound like someone's told them they should do something. Almost like a parent figure's been telling them they should do something. And "I must" or "I will do this." How about "I might do it," "I may do it"? Just relaxes a little bit, doesn't it? Rather than, I've got to do this, I must do this. What a lot of pressure on their shoulders. I could do this, I might do this, I may do this. Just eases up a little bit. And then the Boynian pattern, this was created by a pioneer in the field of hypnotherapy, Gil Boyne, passed away a few years ago. If you hear something where you can do with a little bit more detail. So they say, oh, I'm anxious about doing that. Then you can ask them to complete the sentence. I'm anxious about doing that. And you go, because? And allow them the space to complete that. And once they've completed it, I'm anxious about doing that because if I go to that restaurant and sit down for a length of time, it's going to hurt. So I won't do it. Give them the space. They may have a little bit more to say. Silence is wonderful. It gives them the opportunity. They may not finish processing. I learned that from someone who told me very early on that in my feedback form, which I used back then when I first started for the first couple of years, I would give them a feedback form to see whether there's anything I could have done differently and whether they'd got what they wanted. This is not about my ego. And someone said to me, it was great, but there was one point where I was still processing stuff. And I thought I'd given them enough time, about a minute. But they needed more processing time. They were still thinking about it. So I know we can be limited in terms of time, but we don't have to necessarily do it there and then. If you can, perhaps email in between. So I can't sit for a long time because, I don't know, it'll hurt, and that means I can't go out with my friends. I know things will get worse because my last specialist told me I need an operation, and that means nothing else is really going to help. Wouldn't it be useful if we just knew this stuff? Like we've asked these questions, we've eked out that detail from the person. And if someone starts out by saying, well, I can't, it might be, well, I can't talk to anyone about this pelvic pain because, well, it's not like any other pain. It's embarrassing, we don't talk about that stuff. And that means I'm alone. So it might be that this person, we need connection in their life, or they need connection in their life. And here's the question. So what was going on in your life in the year or two before the pain emerging? Whether the pain emerged because they had an accident or an infection or whatever it might be, or an injury. This is just to see, well, you know, if their injury healed or they recovered from the infection, their pain has persisted, what was the state of their nervous system that might have meant their pain then persisted? So we're just getting an idea. And now for some people, there may be an obvious trauma that happened in the preceding year or two, in which case, you know, it might be time to either refer on to a trauma-informed therapist, or they become part of the team, whatever might be more appropriate for that person. And other times it may not be an obvious trauma. It may be just a drip over time of whether it's adrenaline, that fight or flight response, just at a low level in the background, just sensitizing their nervous system, keeping them on edge. But the answer to this may indicate whether they need to be referred on or they need someone else as part of their team, someone psychologically informed if you're not that person. So let's do a quick exercise in the room. And we can do this if you are sitting here and you've got a low-level discomfort or ache, or you're thinking of something you need to do and a little bit of an emotion comes up. Be playful with it. Be curious with it. We're not expecting some kind of miracle. Just notice what it's like for you. And if you were to allow your eyes to close, and if you're not comfortable doing that, you can just pick a spot somewhere and just sort of focus on that instead. And just tune into your whole body, maybe scanning from the top of your head slowly down to the tips of your toes. And notice if there's any area where you already notice some discomfort or a sensation. It may just be that something's too warm or too cold. maybe something in your muscles too tight somewhere. Just find something specific. Or maybe it is an anticipation of something coming up and an emotion is coming up. And the question for you is, what kind of sensation or what kind of reaction is that reaction? Or what kind of sensation is that sensation? If you could give it a colour, what colour would you give it? There's no right or wrong. The first thing that pops into your mind will do. And just give it that colour right there. If it had a shape or a form to it, what form or shape would that take? And just notice the qualities of it. Some people may notice there's a tension somewhere that's like a band across their back. And the question would be, what kind of band is that? What colour might you give the band to represent the sensation? Or what needs to happen to the band for things to ease? Or someone says their feet feel like they're on fire. What kind of area does that fire cover? What do you want instead? I've had a client say, "Oh, I'd like to imagine just putting my feet into the sea, the cool sea." So as you tune into your sensation or reaction or response or whatever it is, and you've given it a colour and a shape and a form, see how you might change it to a different type of metaphor or a different colour, just representing it differently in some way, just bit by bit, just to see what may change. And I'm not saying that it will completely ease right now. But you may play around with this tool, experiment with it, be curious about it, bring playfulness to it. Whether later or sometime during the week, it might just come to mind for you to just spend a bit more time with it, see what it's like. When you're ready, just take a breath and open your eyes, return back into this moment, feel your feet on the floor. So I know we've quickly just run through a few things. So language patterns that can reveal more about what's going on and potentially suggest a direction. Some questions there, that Boynian pattern, the experience, because, and that means, that pattern, that may uncover priors or suggest a question that suggests psychological input, or psychologically informed therapist as being part of the team. And then an adaptable tool for you to go away and play with and perhaps just see how you get on with it, knowing that it isn't for everyone. I sometimes use it. I don't use it very often, but I will use it with an appropriate person. And just because it doesn't work for you doesn't mean it might not work for that person. If that person is quite imaginative, then go ahead and use it. If they're quite metaphorical in their language, go ahead and use it. So what's next? Well, I wouldn't mind someone doing a study where we can measure indirect hypnosis, so it's internal locus of control promoting, whether that's QCH or any type of indirect hypnosis. I don't mind, as long as it's internal locus of control promoting, with a focus on quality of life rather than pain reduction, a focus on living life to their values, and maybe a follow-up at some point to see whether what sort of impact that has had on that person's life. So thank you. That's Persuading Change. Okay.
Can you hear me? Oh, there
Yes.
we go. I have a question about aphantasia.
Yeah.
I have a hard time with visualization, and I want to believe that neuroplasticity will let me get better at that. And I was curious to know if there was any data to support that.
No,
No.
not at the moment there isn't. Can you imagine the colour of your front door? Can you recall it right now?
Maybe. I'm not sure how accurate it is, but
It doesn't have to be accurate. You can just get a sense of it. Can you think of a face of a loved one? Can you recall their face to mind?
what I find I can do is I can do specific features, but not the whole. So I can visualize, like at the beach, I could visualize a tree or maybe the water, but not the whole picture.
You can visualize, you can build on that.
Great. Thank you.
There is a questionnaire, the VVIS, or VVIQ, vividness of, what's it called? VVIQ, look it up. And it will tell you whether you might be aphantasic or what kind of, where you are on the spectrum. But genuine aphantasics, there are very few, as far as we know. Yeah.
Thank you. I really enjoyed the talk, and like 7 questions came to mind, but I
7 questions?
Yeah, I narrowed it down to 2 first. Would you say there's a difference between asking a question to a patient and inviting introspection? So just say, hey, don't answer it out loud and feel into it. Like, what is your answer within you, versus having them answer first thing that comes to mind? How would you differentiate those two, and why would one be used over the other?
It depends on the person that's sitting in front of you. So if you've got to know them and they're the kind of person who likes to verbalize out loud, then you want to give them the opportunity to do that. But if they want to sit within themselves, it's not really up to us to say just sit with that. That might be really uncomfortable. They might think, oh gosh, that's what I've got to do and I've got to sit with it. And that's so the embodiment work we did in the workshop, that can be quite challenging stuff. I wouldn't introduce it anytime early on if someone's got persisting pain or trauma or anything like that. But if they do sit with it, you do want to give them that space to voice it. They don't want to suppress it really and keep it in their body. They do need a space to voice it. But you will know the person that you're working with. Just get a sense of that.
Awesome, thank you. And then the second question is a little bit of an alternative question, but you may have a thought or opinion on the rise of psychedelic-assisted therapy and research around that space with pain, or if you have any thoughts on that. Thank you.
Should we have a good conversation about that afterwards? Me, you, Laura Rathbone.
Definitely down for that. All right, thank you.
Is that all right, Laura?
Sorry, I have one more question. I think the language piece is so important, and I've heard of neurolinguistic programming kind of courses, and I'm curious to know your opinions on that. Is that something that's worth pursuing? Is it not evidence-based? Where does that stand within this idea of language?
Well, I've trained in neurolinguistic programming. There's quite a lot of, what shall I say, bullshit? Can I say bullshit? But there are some useful things within it. They use language patterns too. There's lots of crossover. It's just don't take any of it as absolute fact, just take and leave it. If they say this process works because of X reason, no, it doesn't. There's no evidence for any of it, anything in NLP. But if you can find some useful tools, and there's certainly some useful tools and ideas in there, then go for it.
Thank you.
Yeah. Sorry for swearing.
Appropriately used. And actually, so that's perfect timing.
Great.
We'll take a little break and wake up for our next and final session with Laura Rathbone.